Are you ready?
Yeah.
You are at 30 or 9.
What? Okay.
So she already had her.
So she wanted to make a transition. We just know she wanted. All right, welcome everyone to THETA Rounds 2018, first one. We've got our very esteemed guest today, David Naimark, and I'm totally unprepared to introduce. I was just told I should be doing that. Anyway, David is a nephrologist at Sunnybrook Hospital. He's also an associate professor, I think, at IHPME. He's my partner in crime in teaching decision analysis and modeling. I'm doing the intro, and he's doing all the crazy advanced stuff. That's kind of really, really cool. And so we'll be talking about modeling today around kidney disease, what you would expect. Anyway, so it's short and brief today. We will still go around the room, and everyone, please introduce yourself.
Hi, my name is Leah. I'm a biostatistician.
Hello, same.
Suzanne, I work at THETA at RA.
Alex, health economist at THETA. Austin, PhD student at THETA.
Troy, research associate at THETA. I'm Rafael, I'm a postdoc here.
I'm actually a PhD.
I'm Manuel Young, health economist at Health Quality Ontario as well.
I'm Naimark, research associate at THETA.
I'm Peter Dixon, a master's student here.
I'm Lily, I'm a PhD student at the faculty at Naimark UFT.
Eric Loplum, I'm a biostatistician at the Diabetes Center at Mount Sinai.
Valorek, associate director of THETA and scientist with Ted Rogers and Peter Monk here.
I'm Alexandra, I'm a postdoc fellow.
And I'm George Thomas, I'm a biostatistician, UHN.
And I'm Beata Sander. I'm a scientist here and associate professor at IHPME. So welcome everyone, and hand it over to David.
Okay, well, thank you for coming out on this frosty January day. So just as Beata mentioned, I'd like to talk about chronic kidney disease and some of the health services research and modeling work that I and my colleagues have been doing. So I'll be talking about non-dialytic chronic kidney disease, so disease that's not to a point where dialysis is required. So for the benefit of the biostatisticians and health economists, I'm just going to talk a little bit about what the kidney does, okay? Because I need you to understand what it does so you'll understand the metrics that I'm talking about when we model, okay? So this is a cartoon of a nephron, okay? Each of you has about 1 million of these in each of your kidneys, so about 2 million of them total. And the main parts are, there's a filtration unit called the glomerulus, and it's followed by a reclamation unit called the microtubule, okay? So the glomerulus filters a large volume of the liquid part of blood every day, and then the reclamation unit reabsorbs about 99% of that water, okay, and anything that's biologically good for you, and it lets the rest, 1%, go as urine, okay? So all the bad metabolic waste is concentrated down into 1% of the filtered volume, okay? And the thing that we kidney doctors are very concerned about is the glomerular filtration rate, okay? So the volume of filtrate produced per unit time, okay? That's our official measure of kidney function, okay? And we estimate that with a measurement called clearance, okay? And the way we do that is we say, let's look at the mass of a particular marker in the blood that's filtered per unit time, and divide that by the concentration of the marker in plasma that provides a volume of clearance. So for example, if I put an intravenous into you and I infuse something called inulin, which is an inert marker, and establish a steady state concentration of that stuff, then what I'll do is I'll measure the mass of inulin excreted in the urine per unit time, and I can do a calculation that gives me clearance. So at the bottom here, I have how many grams per minute of inulin are cleared in the urine, and I divide that by the plasma concentration in grams per mil, and I get mil per minute, okay? So that's the volume of is an estimate of GFR. Simple, no? Okay. And, you know, in normal men and normal women, there's a decline in inulin clearance as we age, unfortunately. Inulin is precise, but it's very hard to work with. It's impractical in the clinic to be doing infusions of inulin. So in the clinic, we use an endogenous marker called creatinine, okay? And so instead of estimating GFR with an exogenous marker like inulin, we estimate GFR with an endogenous marker like creatinine. We calculate creatinine clearance. The calculation is exactly the same. I'm just going to make the assumption that creatinine is constant concentration in plasma, but I can do a clearance, okay? So, and I do this in the clinic. I send people home with a jug and I say, okay, pee into the jug for a whole day, all right? And you can imagine that's not a popular thing for people to have to do, lugging a jug of urine around, you know, to work, et cetera, et cetera. It's embarrassing to have to explain why you've got a jug of urine with you, all right? So instead, there's been a number of estimating equations that have been published to avoid people having to collect urine, okay? And the first of these was published in 1972, and the clinicians will recognize the Cockcroft-Gault equation for GFR, which is now obsolete, okay? My colleague Andy Levy and company devised a new GFR estimate equation called the MDRD equation in 1999. And in 2006, clinical laboratories in Ontario started to automatically report the estimated GFR every time a creatinine was submitted. And then that equation was updated about 8 years ago to the now CKD EPI equation, which is now the standard. Okay. So these estimating equations require a serum creatinine measurement, age, gender, and race, where race is binary, African American or not. Okay. The other key metric that we look at is proteinuria. Okay. So normally the glomerulus filters a protein-free filtrate. Okay. All of the blood proteins are retained in the capillaries and are not allowed to get through into the urine. If there's any damage to the glomerulus via diabetes or vascular disease or hypertension, then there's damage to the little capillary membranes and proteinuria leaks, and protein leaks through. And the degree to which there is proteinuria is a marker of the degree to which the glomerulus is damaged. Okay, so again, you can use a timed urine collection to estimate grams of protein excreted per day. It should be really 0.01 grams per day. Okay, but again, that's inconvenient because it requires a collection. Okay, you can do a collection for albuminuria, and for some reason, we typically, instead of referring to measuring in grams per day, we do milligrams per day, but still requires a urine collection. You can measure albuminuria in a spot sample of urine, milligrams per liter, but then there's issues with concentration. You know, if you have a concentrated urine, it's going to make the albuminuria look bigger. So what we do is we do an adjustment for creatinine. So we say, how much albumin do you excrete per unit excreted creatinine? Okay, because albumin and creatinine are concentrated or diluted to the same degree, is an adjustment. Okay, and that gives us the urine albumin to creatinine ratio, or ACR. Okay, so the two key indices for epidemiology and nephrology are estimated GFR and ACR. Okay. And we classify CKD according to those two measures. So we do GFR on albuminuria. Okay. These percentages of the general population that have these degrees of albuminuria and GFR if extrapolated to Canada, we would expect that the red squares, severe kidney disease, would equal about 455,000 people in Canada. Moderate or severe is 1.3 million, and any form of disease at all, so excluding the green squares, about 4 million Canadians. Okay, and these have implications. Okay, so whether you're looking at all-cause mortality or cardiovascular mortality or end-stage renal disease risk or acute kidney injury disease risk, it all follows degrees of ACR, degrees of eGFR decline. Okay, so with that intro, that brings me to my objectives. So my objectives today are two. One is to enumerate the clinical and health policy decisions in patients with dialytic CKD, and then to explore how health services research that I've done and others have done and decision science can help to inform these decisions. Okay. So my sort of framework to discuss these issues is, you know, a patient or person or group of people with a steadily declining GFR. Okay. So what are the questions, what are the decisions that have to be made as people progress with CKD? So the first would be which patients should be screened. Which should be referred to somebody like me. Okay. Among those, and a social worker and a dietitian and a pharmacist. Okay. And among those, when should patients start to begin preparations for renal replacement therapy, that is dialysis or transplantation? Okay. And then finally, when should people start dialytic therapy? Okay. So today I'm going to deal with the latter three decisions. The last decision is probably kind of funny to say, but the easiest. Reasonable consensus and certainty about this. So that comes from a randomized clinical trial that was published in 2010. It was done in Australia and New Zealand, where patients who'd reached eGFR stage 5 CKD, according to that classification I showed you, were randomized to either initiate dialysis, quote unquote, early, that is with an eGFR of 10 to 14, or wait for an eGFR of 5 to 7, so late start. Okay. So the top panel is the time to initiation of dialysis from randomization. Okay. So the early group started early, the late group, there was a delay. Okay. The bottom panel is just the resulting time to death. Okay, absolutely no difference. Okay, so there had been observational literature suggesting that early start was good for you, but you know, as often happens in nephrology, we have a lot of observational studies, but when put to an RCT test, they fail. Okay. So in fact, there's so much consensus about this, there's an infographic for this for patients. Okay. So if I just direct you to the bottom right-hand part of the slide, what the Canadian Society of Nephrology recommends about when to start dialysis: intent to defer. The idea is we don't look at numbers so much anymore, we look for symptoms, okay? We don't start people on dialysis until they start to manifest uremic symptoms, okay? At no particular number. It may be higher for some people, lower for others. Intent to defer until symptoms develop. Okay. Now, when should patients start preparations for either transplantation or dialysis? All right. So I would say this is a bit of a thornier question. All right. So when I say preparation, what exactly do I mean? Okay. So preparation differs according to the type of renal replacement therapy that patients are going to want to follow or do. So if it's hemodialysis, then what we mean by preparation is the creation of an arterial venous fistula. Okay, I'll describe what that is in a second. If they're going to do home dialysis with home peritoneal dialysis, it means the insertion of a peritoneal dialysis catheter. Okay. If they have a potential donor, a kidney donor, then they may opt for preemptive transplantation to try and transplant before dialysis is necessary. Okay. And preparation entails assessment of the donor and assessment of the recipient for the suitability for transplantation. Okay. And as you'll see, I mean, in the clinic is really when to do these things. Okay. So just talk about hemodialysis and an AV fistula. What is an AV fistula? So what we do basically is we do an anastomosis between a vein in the arm and an artery in the arm. Okay. So in the forearm, it's the radial artery and the cephalic vein. Okay. What this does is it causes the cephalic vein to expand into a big pipe. All right. And when it's fully mature, then we use needles to draw blood out of the fistula, run through the machine, and return to the patient. Okay? So when everything works well, this is what it looks like. Okay? So, you know, it's disfiguring. All right? You know, we think this is a big success because we have a big pipe, we can get blood out of this, but, you know, it's, I don't really want to have people have to walk around with this, you know, and for too long a period before they need dialysis, okay? And certainly one of the issues we face in chronic kidney disease is the competing risk of mortality. So I certainly don't want to have people go through the cost, discomfort, anxiety of creating this and then never use it, okay? And these things are not entirely benign, okay? Like the surgeons always have their pictures, so you know, fair warning, trigger warning, okay? So they can rupture, okay? They can cause distal ischemia in the hand, all right? So they're not entirely benign either. When I talk about PD preparation for peritoneal dialysis, that's insertion of a PD catheter, okay? This is what it looks like. You know, again, I want to time this so I don't have to subject my patients to having to walk around with this too long before it's needed, okay? A, because that's an infection risk. B, because it's unsightly. C, again, competing risk. I don't want to have to do this to somebody if they'll never use it, okay? Preemptive transplantation involves a very extensive list of investigations, okay? A lot of them are not too bad, blood tests, but it can include colonoscopy, it can include cardiac catheterization, it certainly involves ultrasounds and echoes, and it's a lot of expense and cost and time for patients to engage in. So again, you know, the other issue is that often these investigations have to be repeated annually. So I don't want to start too early because I'll just have people run through the mill of having to go through these tests, a lot of testing before they actually have the transplant, okay? So it really is, the big question I think is when, timing. Okay, so you may think, well, all right, question?
Just wondering with the timing, like they are not all happening at the same time, right? And like what time frame are you talking about, like months?
Time frame for like how long things take? You mean how long they take?
Mm-hmm.
Okay, I'm gonna, good question, because that's what's coming up next. Okay. So you would think, well, right, okay. Let's say we want to initiate renal replacement therapy when the eGFR is 5, okay? Let's say our estimate of a patient's slope is 10 mil per minute per year, okay? And we'll imagine the preparation takes 6 months, okay? So when we start preparation, when the eGFR is 10 mil per minute. Simple, right? No, not so simple. Why? Well, as I showed you, we don't start renal replacement therapy at a fixed value anymore. We wait for symptoms, okay? And we never know when those symptoms are going to develop, okay? We don't know how long things take, okay? So for example, for fistula, the maturation time in the fistula is variable from patient to patient, okay? If I put a fistula in your forearm, it has a 40% chance of failing, in which case I have to move to the upper arm and have to do a more extensive operation and wait for it to mature, okay? If I plan for peritoneal dialysis, again, those catheters just don't always work. So I may have to manipulate it, I may have to move it, I may have to, you know, it may not work. So I can't guarantee that your PD catheter will be available for you at any particular time, okay? Transplant workups can go on for months, okay? It's a whole scheduling. And then the donor may be found to be unsuitable or the donor may renege. So I don't know how long things are going to take, okay? And then also, I don't really know what your slope is, okay? So apart from that, this paradigm works well, except nothing works, okay? So let me just tackle the slope issue for a second, okay? So this idea presumes that your kidney disease is well-behaved. And by well-behaved, I mean progressing at a steady rate, okay? Well, there are certainly diseases that don't behave well, okay? So this is a case that stands out in my mind. This is a patient who had lupus nephritis and was doing great, and then, all right, had to start dialysis in an emergent fashion because her disease exploded, okay? The other is, I don't know at one point, a person who does have a well-behaved disease, who's progressing steadily, excuse me, will develop an acute kidney injury episode. They have a cardiovascular event, they get an infection, they have trauma, okay? There's some damage to the kidney, okay? Suddenly it drops their function some, all right? And now things are happening faster than I expect, okay? The other issue is that creatinine is I'm going to choose my word carefully here, is a shitty test, okay? It's noisy, okay? The assay, creatinine has biological variability day to day, okay? And big time assay imprecision, all right? This is just a random sample of the patients in my clinic, okay? 0 here represents the average creatinine of a person, and these lines just represent the highest and lowest value of the creatinine for those people, just to give you an idea of the degree of variation. There was a study that was recently published about a coefficient of variation of creatinine measurements in inpatients, and it was 11%, which is really big. It's really noisy. And worst of all, the noise gets worse the lower the true GFR is, okay? So the people in whom you really would like to have precise estimates of creatinine values are the people in whom the imprecision is the worst, okay? And this is just considering a static. If you're trying to determine slope, it becomes even more difficult. So sure, for a particular patient, if I have lots of measurements, okay, I can get a reasonable idea of what the slope is like. But often we don't, and with sampling error, I can get a false idea of what the slope is for a person. And then what I've alluded to before is the other issue that makes the decision about when to proceed with renal replacement therapy difficult is the competing risk issue, okay? So this is a classic study now in nephrology that was done in the Kaiser Permanente data set in 2004. Just looking at the stage of chronic kidney disease upon enrollment in the Kaiser Permanente health insurance system, okay? and then outcomes 5 years after enrollment. Okay, so to 90 GFR with and without proteinuria, 30 to 60 GFR, i.e. stage 3, 15 to 30, stage 4. Okay. The blue segments are the people who died within that 5-year period. The stippled area are the people who went on to dialysis. Okay. So certainly stage 3, the competing risk of death is really overwhelming. And even in stage 4, the pretty severe chronic kidney disease, more people die of predominantly cardiovascular disease than go on to dialysis. Okay. So this complicates my life as a clinician a lot because, again, I don't want to put people through the potential side effects, pain, cost of preparations if they're going to succumb to a competing risk and never go on to dialysis. Okay. So that motivated us to try and develop a predictor, okay, that used more than just eGFR to help us determine when to do people. Okay, I'm aging myself, but I joined the faculty in 1997, okay? From 1997 to 2001, I had to go through the pain of working with a paper-based clinic, which is painful, okay? 2001, I said, enough of this, enough of this. So I built an EMR, and it's the one we used at Sunnybrook until 2015, okay? And the side benefit of that was data, okay? So between 2001 and 2008, we accrued 6,200 patients into the database and used that to develop a risk prediction tool, clinical prediction rule, to help us determine the risk of end-stage renal disease at 1, 2, and 5-year periods. We got some external validation data from British Columbia, so 4,242 patients, stage 3 to 5 CKD from BC, and combined them, developed the kidney failure equation. So these were the baseline characteristics of the development cohort from Sunnybrook and the validation cohort from the British Columbia Provincial Renal Agency. They were very different populations, which actually is good because if you can show that it predicts well in a different population, of different characteristics, that's robust. And a different risk of end-stage renal disease, so 11% in the Sunnybrook cohort and 24% in the BC cohort. Okay. These were the nested set of Cox regression end-stage renal disease risk models that were developed. What was model 6 in the paper has now become the 8-variable KFRA, kidney failure risk equation, and the model 3 is a 4-variable kidney failure risk equation. So they had C statistics above 0.9 in the development cohort and above 0.85 in the validation cohort. And I would say calibration. Okay. So now there's an app. Okay. So you can go to a website, you can download it to your phone. So great. The KFRE has been super validated in a consortium of CKD cohorts called the CKD Prognosis Consortium. My former student, Navdeep Tangri, validated this in 700,000 chronic kidney disease patients. So 721,000 patients among 30 cohorts across 4 continents. Okay, and showed that the 4-variable kidney failure risk equation at 2 years has pretty consistent C statistics around 0.9. And at 5 years, a little bit more scatter, but again, about 0.9. The calibration, this shows the calibration in North American cohorts and in others, okay? It required the addition of a calibration factor for non-North American cohorts, okay? But at least at 2 years, yes, there's a little bit of scatter, okay? But predicted risks are lining up with actual risks reasonably well, okay? So this brought me to the question about what would be the potential clinical benefits and economic impact of broad application of using the kidney failure risk equation for the determination of when to start preparation versus just GFR alone, which is what we've been using. Okay. So to do that, developed a kind of natural history Markov model for CKD, and it would start the clock at referral to nephrology and follow people through various CKD stages through to renal replacement therapy and to death. Okay. And this was used data derived from the Sunnybrook CKD cohort, and just to show validation, the left-hand panel is the observed distribution of AKI, numbers of AKI hospitalizations in the CKD Sunnybrook cohort in the black bars, and the modeled hospitalization distribution in the gray. And then cardiovascular hospitalizations, again, observed versus modeled. So reasonably well calibrated. Time to first AKI hospitalization, time to first CV hospitalization. So again, you know, the process of calibration is never perfect, but at least up until 5 years, they track pretty well. This is the modeled and actually observed distribution of renal replacement therapy modality. So in-center hemodialysis, okay, versus home PD, versus home hemo, versus preemptive transplantation. Okay. Numbers of people starting with attempts at fistulas and who started with a fistula. Problem was I was supposed to look up what the real number was, and I can't remember, but it was good. Okay. Here we've got time to end-stage renal disease. So the blue line is the British Columbia cohort. The black line is the observed Sunnybrook cohort, and the gray line is the modeled. Yes? Sorry, end-stage renal disease defined as initiation of RRT. Yeah, there's really two ways to define it. Some people define it as kidney failure, that is dropping to 15 ml per minute GFR. Some people define it operationally as going on to renal replacement therapy. The eGFR standard for end-stage renal disease is objective, but not clinically relevant. Renal replacement therapy sometimes, you know, it's defined as starting of, it really depends on local practice. So it's more subjective, but it's more clinically relevant. So here I'm referring to RRT, to end-stage renal disease as initiation of RRT. Okay. So at least among Canadian cohorts, the BC cohort risk of end-stage renal diseases tends to be on the high side. Sunnybrook tends to be on the low side. So I'm happy to see the gray line kind of meandering between them. Okay. Time to death. Okay. Now time to simulate. So I'm going to simulate two strategies. Our usual way of deciding when to begin RT preparation with FAR, and risk-based using a KFRE. So simulation. So what size do I need? So the microsimulation sample size at the size of the CKD cohort at Sunnybrook, and then determine how many outer loop iterations required, and it turned out to be about 5,000. Okay, so all of the results you'll see will be for 5,000 outer loop iterations, each of which having roughly 3,400 people in them. Now, an issue is threshold effects, okay? So I can get different behavior of a strategy for RRT preparation initiation depending on what threshold I choose for EGFR versus what threshold I use for KFRE. So the first order of the day was to find the optimal threshold for both, okay? So this is an initial simulation to say what 2-year probability threshold should I pick to say, okay, that's when you proceed. And how many of those values do I require? Okay, should I wait until I have 1 or 2 or proceeding? Okay. Similar with GFR threshold, what mil per minute should I use and how many low GFR numbers should I use before I say, okay, go ahead. So the Z-axis here is the percentage improvement in terms of optimal outcomes for preparation. That is people getting the modality that they desire, people not crashing, having to start dialysis without adequate preparation, and people having preparations that actually are used. So that's defining optimal. Okay, so I'm looking for the combination of number of signals and threshold that gives me the optimum for both GFR and KFRE. Okay, so the idea is when I do the modeling exercise, I'll compare optimum to optimum. Okay, okay, so I did that. So here are the kind of clinical simulation results. So the gray bars are using the 2-year KFRE, and the stippled bars are using our standard practice of GFR determination of when to begin RRT preparation. Okay, so looking at the people that had some planning prior to initiating ESRD, so the people who didn't have that are the people who had some kind of a cardiovascular catastrophe and ended up in dialysis without any preparation. So better with the equation. The people who started in-center hemodialysis, so these would include people who chose it, okay, and people who had to start dialysis before they were ready, okay. So lower in-center hemodialysis percentages for using the equation. More people starting PD, about the same starting home hemo, a little bit more people doing successfully getting a preemptive transplant using the equation. This other couple of bars are, things are bad. So we wanted to start you on PD or a transplant, but you crashed and you ended up on in-center hemodialysis, so lower for the equation. Among people who did go on to hemodialysis, at least one attempted an access, better for the equation. Actually starting with an access, better for the equation. Not so good for the equation, so more futile accesses. So that's people who had a fistula created but didn't get a chance to use it because of a competing risk. Okay, and futile access that sat around for 2 years without being used. Okay. Okay, so more prepared people using the KFRE versus GFR, a few more people having preparations that were ultimately futile. How about the economic side of things? Not cost effective. Not cost effective. Okay. It may be unfair to use this as a gauge of whether or not to employ the risk-based approach to RRT preparation, because this is really more of a diagnostic test. People aren't acting on it in any way that would alter mortality risk. Okay, this is just when do we begin preparations. Okay, it has clinical utility. Meaningful change in numbers of quality-adjusted life years because we're really not doing anything to affect that. Okay. This is the result of the PSA. Okay. So yeah, significant number of iterations above a willingness to pay of $50,000 for quality-adjusted life year. Yes. We incorporated disutilities for having a fistula, okay, but not specifically for having a futile. You know, you live with the fact you have to have that thing in your arm, okay, but when you die, you can't have disutilities anyway. So you live with the fact. Now there wasn't a sort of oh, thank God I'm on dialysis now and I'm using it benefit. Okay, so here are the cost effectiveness acceptability curves. So as an exercise, I thought, okay, what about if we actually what if clinicians acted on the information? Okay, so let's imagine that every CKD patient has steps taken to mitigate their cardiovascular risk. And among those who have a 2-year risk of needing renal replacement therapy that's above the threshold, will take steps to reduce GFR decline and reduce albuminuria. Okay. So this is running a number of scenarios where the benefit of those equation-driven interventions is increased in their intensity, okay? And it actually doesn't take much to bring the cloud of dots below the line, okay? My collaborators thought that these scenarios were unrealistic, unfortunately. So isn't this a beautiful picture? But it's out of the paper. And then the resulting cost effectiveness acceptability curves. The other thing was, would it be feasible to detect this benefit in a randomized clinical trial setting? So I actually used the model of a kind of super duper sample size calculator, okay? So I ran a simulated set of cluster randomized trials, okay, where the duration of the trial will be 5 years, and the outcome of interest is a binary outcome about, you know, a good RRT preparation or not. All right. And looking at 20 clusters with various numbers of participants per cluster, but adding up to a fixed number for total participants, and looking at the power to detect differences with that type of setup. And it would take roughly, 600 people per group to demonstrate that type of benefit. So 1,200 people on a trial. Well, could be done. Could be done, not impossible. Okay, so everything's great. Yeah, we've got a, we've got a really well-validated tool. Okay, it's shown some promise in a modeling context. There is the potential that it could be taken into the field for a cluster randomized trial. Okay, so everything's great. Yeah. Okay, so Murray, here's my joke. Huh? So Luke, never underestimate the power of the dark side. Okay. So the last thing I want to talk about is which patients should move into multidisciplinary care. Okay. So in May of 2016, the Ontario Renal Network revised eligibility for funding for multidisciplinary care. Okay. So prior to that, you got roughly $1,400 per patient. So the institution got $1,400 per patient, provided that they had an EGFR of less than 33 mil per minute. Okay. And that would support the salary or the time of a pharmacist and a dietitian and a social worker. Okay. It didn't pay me, but these are very helpful people to have to look after these complex patients. Okay. After May 2016, they changed the eligibility. Okay. So now, in order to get that bundle of dollars, your 2-year risk of kidney failure, according to the KFRE, has to be above 10%. Okay. So they took my technology and so I feel umbrage, okay, to put it mildly. The rationale for this change was that we were spending too much time and energy and resources on people who weren't progressing. Okay, I mean, to me, that's penalizing us for our success. We are preventing people from progressing, right? But that's a waste of money, obviously, to them. So we went through our own Sunnybrook cohort and said, well, what would be the implications of the new change? Okay, just going through the old criteria and the new criteria. So how many patients would be eligible for this bundle of funding under the old way and the new way, under the old way only, under the new way only, and eligible for neither. Okay, and we estimate that the proportion of people who will qualify for this extra care will drop by 45%. Okay, and who does it predominantly impact? Okay, this is taking the 2-year kidney failure risk equation and back calculating. Okay, so what I'm looking for are combinations of ACR and EGFR that would qualify you by age. Okay, this is for men. Okay, so if you are above and to the left of one of these lines, you qualify. If not, you don't. Okay, and you can see as people get older and older and older, the region, the qualification region shrinks. Okay, and why is that? Why is that? Because older people die. So we are penalizing the people who are most frail and at risk with this paradigm. Okay. And this is the probability isocontours for women. Okay. Couple of students that were in Peter Coyte's class, Intros to Health Economics, and I used information on the benefit of multidisciplinary care and the cost of multidisciplinary care, and plugged that into my natural history model and showed that this was a very bad economic idea. Okay. Now, I have to say that this is preliminary because we really need to look carefully at the studies of the benefit to make sure it's not just selection bias. Okay. But taken at face value of potential benefits of MDT, it's a strategy that is more costly and less effective. Okay. Okay, so that's where I'm going to stop. This is kind of where we are in terms of health services research and modeling for chronic kidney, non-dilated chronic kidney disease, for better or for ill. Thank you very much.
Thank you, David. Open for questions.
I in case of Maria.
Do you think, we've been looking at some of the ORN data for what happens after people are initiated on dialysis, and see that there is a big difference in survival and a big difference in cumulative cost. And I wonder if thinking about what happens after you start will change how you think about how to plan for what happens when you start. Because all dialysis is not the same. And there probably are big differences in survival, and there certainly are big differences in cost. And I just wonder if bringing some of that kind of insight sort of upstream might help you think about what to do as you're thinking about starting dialysis.
Let me say that in the model that I did, it did obviously look at events past the initiation of dialysis. Okay. Also, I think it's important to compare apples to apples. So there are really two populations of end-stage renal disease patients. So there are people who start unexpectedly. Okay, so people who have a cardiovascular catastrophe, have an overwhelming sepsis. Okay, they have an acute kidney injury as a result of that doesn't recover. Okay, those are a very different group of people than the people who progress slowly and methodically through our clinic. Okay, so I think and the people who start in an emergent fashion, in an unexpected fashion, obviously have a much higher mortality risk than people who have had the opportunity to be seen in nephrology clinics. Okay, so I think the answer to your question is yes, absolutely. Think about life after dialysis when making these decisions, but use data from the appropriate population. So, what is the mortality risk after dialysis of people who've been through clinics and who have progressed slowly, and not the whole group of dialysis patients?
So the independent dialysis rate in Ontario is 20% approximately. The independent dialysis rate in places like Singapore are upwards of 60, 70%. So the people we looked at are people who, for the most part, collectively went on to renal replacement therapy. Yeah. And there are these big international differences and huge differences in cost. So anyway, that's really less about what you've done, but I just wonder whether bringing in some of those differential mortality and bringing in some of those differential cost effects might change how you plan for dialysis, for example, who you send for fistulas, who you send for PE catheters, the kind of training for home dialysis, for example, you might initiate. So I'm just wondering about the idea of sort of differentiating the pre from the post, because I think those things are probably pretty related.
Yeah, it's a good point.
I had a question, so I was wondering for the risk prediction model or equation, if you have thought about if there's even relevant to link to administrative data and have a longer follow-up, or have some other data available that's not, I guess, in your database.
So that was done with the international validation. So among those 30 cohorts were some that had extremely long follow-up. So yeah, that was done. Yeah.
Everyone's still tired from too much
partying to mortality. Anyway, so thanks a lot, David. I really appreciated you coming here, and great round, great start to the new year. Thanks, everyone. I'll be back next week, I think, for the FE round, and in 2 weeks, the THETA round. Are we going to move up this person, or does it mean? Move to the next 3 questions. I think you have 3 more.
There were a couple more questions. Yeah.